Good afternoon. I'm Keisha Bohannon, and I work in the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention. On behalf of CDC's One Health Office, welcome to the September 3rd, 2025 Zoonoses and One Health Updates call. Next slide, please. Although the content of this webinar is directed to veterinarians, physicians, epidemiologists, and related public health professionals in federal, state, and local positions, the CDC has no control over who participates. Therefore, please exercise discretion on sensitive content and material, as confidentiality cannot be guaranteed. Today's webinar is being recorded. If you have any objections, you may disconnect now. Links to resources from each presentation are available on our website at cdc.gov/1-health/php/trainings-events/September-2025-zohu-call.html. Next slide, please. Today's presentation will address one or more of the following 5 objectives. 1, identify an implication for human, animal, and environmental health. 2, identify a One Health approach strategy for prevention of public health threats. 3, identify a One Health approach strategy for detection of public health threats. 4, identify a One Health approach strategy for responding to public health threats. 5, list 2 ways to improve collaborative practice across the public healthcare team. Next slide, please. In compliance with continuing education requirements, all planners and presenters must disclose all financial relationships in any amount with ineligible companies over the previous 24 months, as well as any use of unlabeled products or products under investigational use. CDC, our planners and presenters wish to disclose they have no financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Content will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial or in-kind support for this activity. Next slide, please. Instructions for receiving free continuing education are available at cdc.gov/1-health/php/zohu/index.html. To receive free CE for today's webcast, sign in or create an account at train.org by October 6, 2025. The registration code is ZOHU webcast. A captioned video of today's webinar will be posted on the September call page within 30 days. Free CE for the web on-demand video of today's webinar will be available until October 7th, 2027. Next slide, please. Before we begin today's presentations, CDC One Health Office Director, Dr. Casey Barton-Baravesh, will share some news and updates.
Good afternoon, everyone, and thank you for joining us for our September ZOHU call. We're very happy you are here with us today. And as always, we ask that you please share the ZOHU call website link with your colleagues from public health, agriculture, wildlife, plant, environment, and other fields and sectors so we can let them know about the live and recorded webinars and free continuing education that the ZOHU call offers. Before we start the presentations, we want to share some monthly news and resources, and you can find the links to these in today's ZOHU call email newsletter. If you are not yet subscribed to the newsletter, you can sign up by using the link on our main ZOHU call webpage, so moving forward, you get these updates. CDC is working closely with USDA and other partners to respond to an outbreak of New World screwworm in Central America and Mexico. You can find the latest updates on USDA and CDC's websites shown here. Next slide. CDC has also developed a short survey to better understand backyard poultry owners' views about bird flu, and CDC will use the survey results to improve H5 bird flu prevention activities. So you can scan the QR code on the screen and go directly to the survey page, or you can type in redcap.link/backyardflock to access the survey. And we ask you to share this widely with your One Health partners who might have backyard flocks. Next slide. In today's newsletter, we share some recent publications, including one on tetrahydrocannabinol intoxication from food at a restaurant in Wisconsin from October 2024. We also highlight a publication about enteric disease outbreaks associated with animal contact in the United States from 2009 to 2021, and another publication on an outbreak of Salmonella typhimurium infections linked to commercially distributed raw milk in California and 4 other states. Next slide. The newsletter also highlights recent announcements and resources, including a resource page with food safety educational materials and videos, as well as a web page on rabies in the United States and protecting the public health. Next slide. There are several September observances that might be of interest, including National Preparedness Month and National Food Safety Education Month. September 7th is a National Clean Day of Air, as well as World Field Epidemiology Day. September 15th through the 19th is Fungal Disease Awareness Week, and September 28th is World Rabies Day. Next slide. Finally, there are ongoing outbreak investigations, including multiple salmonella outbreaks linked to different sources like frozen sprouted beans, pistachio cream, backyard poultry, and pet geckos. There's also an ongoing lizard outbreak linked to chicken fettuccine Alfredo meals. You can visit CDC's Healthy Pets, Healthy People website for a selected list of ongoing and past U.S. outbreaks of zoonotic diseases. And linked from today's newsletter, you can find details about additional ongoing U.S. outbreaks. We invite you to continue sending presenter and topic suggestions for future ZOHU calls, as well as news from your organization. You can send that to us at zohu-call@cdc.gov. That's ZOHU-CALL @cdc.gov. Next slide, and back over to you, Keisha.
Thanks, Casey. You may submit questions at any time using Teams Q&A feature. Please include the topic or presenter's name. The Q&A session will follow the final presentation if time permits. You may also email questions to today's presenters. We've included their email addresses on the slide and in today's email newsletter. Next slide, please. Our first presentation, extensively drug-resistant Campylobacter jejuni linked to pet store puppies, will be shared by Doctors Louise Francois Watkins and Sean Stapleton. Please begin when you're ready.
Thank you, and good afternoon, everyone. So today we'll be talking about extensively drug-resistant Campylobacter jejuni linked to pet store puppies. My name is Louise Francois Watkins, and I'm a medical epidemiologist with CDC's Division of Foodborne, Waterborne, and Environmental Diseases, and I'll be co-presenting with my division colleague, Dr. Sean Stapleton, who is a veterinary epidemiologist. Next slide. So just a brief reminder that the findings and conclusions in this report are ours and do not necessarily represent the official position of the CDC. Next slide. In October of 2017, an Ohio resident named Mike was hospitalized with a severe Campylobacter infection. His illness developed about 7 days after he brought home a new puppy, Mabel, from a local pet store. When Mike didn't get better, his physicians discovered that the strain causing his infection had a rare resistance pattern that included resistance to all antibiotics recommended for the treatment of Campylobacter. He required ICU admission and treatment with a carbapenem antibiotic before he eventually recovered. A sample of Mabel's feces tested positive for the same strain. Next slide. Campylobacter isolates from Mike and Mabel were linked to a multi-state outbreak investigation. Whole genome sequencing identified cases from people and puppies in 17 states. Ultimately, pet store puppies from a national pet store chain were strongly implicated as a cause of outbreak illnesses. Next slide. Mike's story is a reminder that pets are great companions, but they can sometimes share germs that make us sick, and most U.S. households include pets. Animal contact investigations often require working within a One Health framework to collect epidemiology information and perform laboratory testing and traceback. Often, the animal vehicle persists in the community even after the outbreak is solved, and cases continue to occur. Unfortunately, that was the case for this particular investigation, and we continue to see cases 8 years later. Next slide. Our objectives today are to describe human illnesses with extensively drug-resistant Campylobacter jejuni and discuss factors that contribute to the prevalence and spread of these strains. To describe how public health investigations have resulted in identification of possible upstream reservoirs of Campylobacter within the pet industry, and to describe the resources available to veterinarians and public health officials for testing puppies for Campylobacter and for educating stakeholders, including pet owners, breeders and distributors, pet store owners, public health officials, veterinarians, physicians, and the general public, about strategies for preventing pathogen transmission from puppies to humans. I'll start by providing a brief overview of campylobacteriosis and explaining how CDC currently monitors for cases of extensively drug-resistant Campylobacter. And then I'll turn things over to my colleague, Dr. Sean Stapleton, to review what we know about reservoirs and to share some resources. Next slide. So I think this audience is probably fairly familiar with Campylobacter, but we'll just quickly review a few basics. Next slide. Campylobacter is a genus of spiral-shaped gram-negative bacteria. Multiple species are capable of causing human illness. I've listed the most common ones here. Campylobacter jejuni causes about 90% of human illnesses, followed by C. coli, C. upsilonensis, and several others. Next slide. Dogs, especially puppies, can also carry Campylobacter species and shed the organisms in their feces. C. jejuni and C. upsilonensis are the most common species in dogs. Often, dogs may be completely asymptomatic. Next. But other times they can have symptoms, including fever, malaise, and diarrhea. The typical incubation period for Campylobacter infection in people is about 2 to 5 days. Most people with campylobacteriosis have diarrhea that can be bloody, fever, or stomach cramps, and symptoms usually end within 7 days, although some people can get quite sick and require prolonged hospitalization. Complications are sometimes more severe than the illness itself and include irritable bowel syndrome, reactive arthritis, and Guillain-Barré syndrome, a condition that causes muscle paralysis. Next slide. Transmission is typically via contaminated foods, especially raw or undercooked chicken or other poultry, and less commonly beef or other animal products. Illness may result from cross-contamination during food preparation. Consumption of contaminated water or unpasteurized raw milk may cause illness, and contact with wild birds, farm animals, pets, or their environments can result in Campylobacter transmission. And then finally, Campylobacter can also be sexually transmitted. Next slide. Most people recover with only supportive care, such as rest, fluids, and electrolyte replacement. However, antibiotics may shorten both the duration of symptoms and the duration of shedding of viable Campylobacter organisms in stool. Recommended antibiotics include macrolides, such as azithromycin, clarithromycin, or erythromycin, or when the infection is known to be susceptible, fluoroquinolones, such as ciprofloxacin or levofloxacin. Members of the veterinary community might be more familiar with a different fluoroquinolone antibiotic, enrofloxacin, which is also known as Baytril. Next slide. CDC performed surveillance for antimicrobial resistance in human Campylobacter isolates from 10 U.S. sites through the National Antimicrobial Resistance Monitoring System, or NARMS program. We consider isolates to have clinically relevant resistance when resistance to macrolides, such as azithromycin, or fluoroquinolones, such as ciprofloxacin, is present. We consider resistance to be extensively drug resistant when resistance to macrolides, fluoroquinolones, and at least 3 additional drug classes is present. In 2023, about 38% of Campylobacter isolates showed clinically relevant resistance, and about 0.6% were extensively drug resistant, to give you some sense of how rare XDR resistance is. Next slide. So now we'll circle back to the strain of XDR Campylobacter jejuni linked to pet store puppies. Next slide. The initial outbreak investigation that I mentioned earlier took place between August of 2017 and January of 2018. At the time, whole genome sequencing was just beginning to be implemented for Campylobacter, so we conducted retrospective case finding by sequencing isolates that had the same rare resistance pattern. And sure enough, we identified related cases back to 2007. Although recommendations were made to the pet industry when the outbreak investigation closed, we suspected that we might continue to see cases due to the ongoing sale of pet store puppies. And indeed, prospective monitoring revealed that cases continued to occur. Next slide. Which brings us to the topic of rep strains. The challenge that we faced following this outbreak investigation, suspecting that related cases might continue to occur, is not unique among enteric diseases. Our division has grappled with multiple problem strains that don't always follow a traditional outbreak pattern. Our division calls these rep strains, which is short for reoccurring, emerging, or persisting. Compared with outbreak strains, rep strains typically cause illnesses over a longer period of time in one of the three namesake patterns. These strains are typically more genomically diverse because they're often passed between humans, animals, and the environment over a period of many years, which supplies the bacteria with the opportunity to evolve. Next slide. So we defined a new rep strain, REP-DBR01, to help us monitor cases prospectively. REP-DBR01 is actually a group of 3 persisting strains of Campylobacter jejuni. These strains are genomically distinct, but they share common epidemiology, including the link to pet store puppies, and common XDR resistance profiles. So for this reason, we decided to monitor them as one problem. CDC's PulseNet team screens all sequenced Campylobacter isolates for new cases of this rep strain monthly using a case definition based on core genome multilocus sequence typing. And when we detect a new case, we reach out to our state and local public health partners to request patient interviews, including information about dog or puppy contact. Next slide. This is the epidemic curve for REP-DBR01 through June 30th of this year. Our most recent data are still considered preliminary. I've marked 2 periods during which outbreak investigations occurred, and you can see that the first one extends back to 2016 because we included some retrospectively identified cases in the case definition for the investigation that began in 2017. Next slide. So here's a summary of what we know about human cases of REP-DBR01. The median patient age is 36 years and 65% are female. Most patients are white, non-Hispanic. About 22% of patients were hospitalized with a median length of stay of 3 days, and no known deaths have occurred. Importantly, 97% of patients reported contact with a dog or puppy in the week before becoming ill. More than 3/4 of these patients have reported contact with a pet store puppy specifically, including people who interacted with puppies as pet store customers, employees, or visitors. And although about 7% of patients reported contact with a puppy from a shelter or obtained directly from a breeder, they made up a minority of cases. Next slide. So this slide shows the resistance profile for REP-DBR01 isolates. For isolates that did not undergo antimicrobial susceptibility testing, we were able to reliably predict the resistance pattern based on the presence of resistance determinants in the isolate's genome. This figure represents a combination of traditional and predicted resistance. More than 90% of isolates meet our definition of extensively drug resistant. Next. Unfortunately, most remain susceptible to meropenem, a carbapenem antibiotic and possible treatment option in humans, although it must be given intravenously. This graph underscores how difficult these infections are to treat, not only in people, but in dogs as well. Next slide. And with that, I will turn things over to my colleague, Dr. Sean Stapleton. Thank you.
Thank you so much. Again, my name is Sean Stapleton. I'm a veterinarian and an epidemiologist. And what I'd like to talk about at this stage of the presentation, as you've already heard, when we were first getting our arms around this issue, it required a rather large multi-state investigation that spanned a number of months. But the way that we know that these infections continue to occur in people as a result of contact with puppies in the modern era this year, say, for example, is really driven by efforts on a single state and local jurisdiction investigations. And so I'd like to highlight one example. Next slide. This slide was created in collaboration with our partners in Ohio who are conducting these investigations. This is one example of a state in which these investigations are ongoing and inform our understanding of the persistence of this problem. So if we start in that orange box along the top, the epidemiologic investigation, if we think about all of the Campylobacter cases that are diagnosed in the state of Ohio. So for example, in 2024, there were over 2,800 cases of Campylobacter reported. And whenever a case is reported to the state health department, a local health department, or the LHD, as you can see there, they're going to attempt to reach out to the patient or the patient's proxy to interview them about what types of foods they might have eaten before they got sick, where they traveled, what types of animals they contacted. And that information is shared with the state health department. The Ohio Department of Health reviews this information on a day-to-day basis, this epidemiologic information. And as it relates to this specific problem, they're looking out for some specific information. So for example, if the patient reports working at a pet store or contact with animals at a pet store or a shelter or a rescue, or if, for example, they might have recently acquired a new dog or a puppy in their household before they became ill, that might trigger some additional follow-up, laboratory follow-up. So moving down to that blue box that you're seeing there, in the ideal scenario, what we would like to have is a stool specimen from our human patient, and if they have a puppy in the household, a stool specimen from that puppy. Those specimens are going to be sent to the appropriate laboratories where they can attempt to culture Campylobacter, and then if we're able to get an isolate of the Campylobacter, perform whole genome sequencing, which you've heard of already today. This is essentially the technique that allows us to know what strain of Campylobacter that we're dealing with. Is it potentially one of these extensively drug-resistant strains that have been known to be linked to puppies in the past, or are we dealing with a different type of strain of Campylobacter that might have might be linked to one of those other sources that you heard about earlier in the presentation? After we perform whole genome sequencing information, that's uploaded to different databases. So for the human data, that's going to be uploaded to PulseNet USA, and the whole genome sequencing for the animal specimen isolate, that's going to be uploaded to Genome Tracker. These are essentially just databases that feed into the National Center for Biotechnology Information, or NCBI. That allows us to compare any Campylobacter that's cultured and sequenced from the human to any Campylobacter that might be cultured and sequenced from the puppy. And if we're able to isolate the same strains of Campylobacter from both the human and the puppy, we can have really strong confidence that the human likely became ill as a result of contact with that puppy, especially if we're talking about this extensively drug-resistant strain. And that triggers a few more things in terms of follow-up to prevent further illnesses and reduce potential routes of transmission, which I'll talk about in a second here. But first, next slide. To talk about how we go about testing animals for this specific issue. In many states in this country, there is public health infrastructure for testing of human specimen for Campylobacter. On the animal side of things, FDA's Center for Veterinary Medicine Veterinary Laboratory Investigation and Response Network, or VetLearn, is a network of 46 veterinary diagnostic laboratories across the U.S. and one in Canada that are involved in a number of public health efforts, including consumer complaint follow-up, antimicrobial resistance monitoring, support for network labs through grants and proficiency exercises, as well as outbreak response and emergency response, like responding to the issue we're talking about to you today. So what that entails essentially is FDA CVM is involved in working with local or state public health investigators to coordinate collection of fecal samples from dogs, testing those specimens for Campylobacter, and performing any antimicrobial susceptibility testing. What I want to emphasize here is that this type of testing is available at no cost to the human to any jurisdiction where you believe that if you're a local health or state health department and you believe that you're seeing human cases potentially linked to contact with puppies, testing through FDA CVM VetLearn laboratories is possible for this issue. Next slide. And so in the instance that we do have strong evidence that supports that people are becoming ill after contact with their puppy, what do we do from there? Well, that kind of depends on where that puppy originated from. So did that person purchase the puppy directly from a breeder? Or did they potentially purchase the puppy from a pet store? And if they purchased from a pet store, where did the pet store acquire the puppy? Were there any distributors involved getting the puppy from the breeder to that specific store? Were there any waypoints on the way to getting to that store? And the reason that we want to know about the industry as a whole, or the web that essentially connects the patient to the source of the puppy, is that this informs how we go about educating the public and addressing any potential environmental reservoirs that might be allowing a bug like Campylobacter to persist in the environment. It allows us to know where we should target our education efforts and our biosecurity recommendations within public health. Next slide. And now I'd like to talk to you about some of those resources that we like to share to educate the public about this issue, to prevent illnesses and reduce the chance that Campylobacter can persist in environmental or other reservoirs. And what I hope you kind of take away from this information is the resources that I share with you today. While we're talking specifically about Campylobacter in puppies, you'll see that these have pretty wide applicability across animal health and public health. So the resources that I'm sharing with you today can be used to tackle a number of different issues, not simply this issue that is the topic of this presentation. Next slide. So first and foremost, I wanted to talk about antimicrobial stewardship. And I know that most, if not all on the call, are well aware of the importance of antimicrobial stewardship and all of the information that continues to come out about antimicrobial resistance and concerns for public and animal health related to antimicrobial resistance. But the main thing that I wanted to emphasize are that this is essentially a commitment as far as antimicrobial stewardship. Making a commitment is probably one of the best things that you can do to make sure that you're staying up to date with best evidence and recommendations. So I've highlighted 2 resources that are out there that kind of detail all of the different facets of antimicrobial stewardship and have really great recommendations about antimicrobial stewardship and antibiotic use in veterinary medicine. Both the AVMA and the University of Minnesota have really great resources and documents that can walk you through this. And the reason I kind of emphasize the commitment of this, and I'll use one example to illustrate this. So when I was going through my veterinary training and when I was in practice over 5 years ago, it was pretty common to empirically prescribe metronidazole to a puppy that comes in with acute diarrhea, or any dog that comes in with acute diarrhea. That was a pretty common practice. But as more evidence has been compiled over the years, that recommendation of should you prescribe metronidazole empirically to an animal with acute diarrhea has become more complex, and using it for, say, every case that's walking in the clinic might not necessarily be the most judicious use of antimicrobials. So I encourage you, if it's been a while that you've reviewed a resource like this, to go back and see what the recommendations are and what strategies have been put out based on best evidence as it relates to antimicrobial stewardship. Next slide. And another facet that somewhat complicates this is that in veterinary medicine, we're not essentially working alone when it comes to instilling antimicrobial stewardship principles. We're also collaborating with pet owners and those who breed and sell these animals as well. And so the Pet Advocacy Network, if you scan this QR code, it's going to take you to this resource. It says PJAC at the top. That was their previous acronym. But the Pet Advocacy Network is a group that's developed and published this resource for sharing information in a plain language context about antimicrobial stewardship and instilling the practice of collaboration between industry and veterinary medicine when it comes to choices for antibiotic use. So if you're ever in communication with a breeder or a retailer or anyone who is asking about antibiotic use in animals, you can use this resource and share that with them and make it easier when it comes to the client communication there. Next slide. So to move on from antimicrobial resistance and antimicrobial stewardship to talk about infection control and biosecurity. These two resources are really excellent. It would take me over an hour to get through either one of them, so I'm not going to get into too many specifics, but I encourage you to use either of these resources developed by AHA or the National Association of State Public Health Veterinarians, as these are really excellent, very detailed recommendation guidelines to use in your clinic or at say a shelter or a rescue. I encourage you to think of this as a team sport. You don't necessarily need to go through all of the recommendations and change your practices at your clinic all in one day, but maybe review these if you haven't had a chance in a while to think about infection control at your clinic or your hospital, and work with not just the veterinary healthcare staff, but also the front desk staff, custodial staff, management to develop essentially the best plan that you can at your clinic, especially if it's been a little bit of time. And the main goal here for reviewing infection control and biosecurity guidelines are to really make sure that if a puppy comes into your clinic and is potentially carrying one of these concerning strains, that they're not necessarily contaminating the environment and allowing for either people or animals to pick up that bug in the hospital environment. Next slide. And finally, education of the public is an important role for both veterinarians and public health and any veterinary healthcare staff. And I think it's pretty easy. I know in my job, it's easy to take for granted that zoonoses exist and that we can, as people, become sick after contact with animals. But the reality is that people in general don't necessarily know that. And particularly someone who has never owned an animal before and this is their new puppy, they might not be aware that it's possible that they could pick up a bug that their pet is shedding. So it's important to share this type of information, to have resources available about hand hygiene and cleaning pet supplies and ways to reduce transmission risks. And if you don't necessarily have time to sit down and talk with somebody about that, CDC has a lot of great resources. I encourage you to print out handouts like the one I'm showing on this slide. Have those available at your clinic, or print out these QR codes and have them posted where people are waiting, or include them as in your pet parent packets as new pet parent packet. Added value can also educate the public about these issues. Next slide. And with that, we'll leave it for questions at the end. We very much encourage anyone that has questions about this topic to reach out to these inboxes. So if you're a local jurisdiction responding to this issue, if you're a veterinarian that thinks you might be dealing with this, we recommend that you reach out to us. We very much welcome that. Thank you for your time today.
Thank you for this in-depth look at Campylobacter, Dr. Watkins and Dr. Stapleton. Much appreciated. Okay. Doctors Rosemary Sifford and Ann Straley will share New World screwworm updates for our final presentations. Please begin when you're ready.
Thank you. Good afternoon, everyone. It's good to be with you this afternoon. I'm Rosemary Sifford. I'm the Deputy Administrator for USDA APHIS Veterinary Services, and I'm just going to share a little bit with you this afternoon about the current status of the New World screwworm outbreak in Central America and Mexico, and the work that USDA is doing in this space. Next slide, please. So just a very quick overview that New World screwworm are the larvae or maggots from the Cochleomya homnivorax fly, and the myiasis that's caused by these maggots is what we're really concerned about. And the reason that this myiasis is more dangerous than your typical blowfly is because the larvae for the screwworm feed on living tissue of warm-blooded animals rather than dead tissue. So an injury or a wound that is invaded by these larvae will become larger and they will eat the living tissue. Next slide, please. So historically, we did have New World screwworm in the southern United States, as well as all the way down through Central America. And this map shows that distribution and the eradication process. So in the 50s, the sterile insect technique was developed, and that was used to eradicate New World screwworm down out of North America and Central America, all the way down to the Darien Gap at the southern tip of Panama. And the reason that that was a good place is because that gave us an opportunity, a great narrow area of land mass to continue using the sterile insect technique to keep the flies from reemerging back up into Central America. Next slide, please. So since that eradication effort, USDA has been in partnership with Panama's Ministry of Agriculture to operate the Commission for the Eradication and Prevention of Screwworm, known as COPEG. That facility is located down in Panama and produces sterile flies. And so for since the 90s, that they have been producing sterile flies and distributing them in the area of the Darien Gap to keep the screwworm population from being able to move back up into Central America. Unfortunately, in 2023, we noticed that there were incursions of New World screwworm beyond the area where we were distributing the sterile insects. And then since that time, the fly has moved northward all the way up to Mexico. Next slide, please. And so some of the interventions that are really important for eradication of New World screwworm are, as I mentioned, sterile insect technique. In sterile insect technique, we release male flies that have been sterilized with irradiation. And the reason that this is effective is because a female New World screwworm fly will only mate once in her lifetime. And so if she mates with a sterile fly and does not produce offspring, that reduces the fly population. And then over time, you can eradicate the population. But that really has to be has companions with robust regulatory controls and surveillance. And by regulatory controls, I'm particularly focused here on movements, ensuring that people or animals that are infested don't move out of infested areas, and making sure that if they do, that they receive proper treatment and there's proper surveillance. And then for surveillance, in order for the sterile insect technique to work, you really have to know where the leading edge of the fly population is, because you need to distribute the sterile insects in that area so that they can push the population back. If you are distributing them in an area that is fully engulfed with a breeding population, it's much more difficult for them to gain ground, because the breeding population will also continue mating and producing more flies during the same time. So it's important that you have that surveillance, so you know exactly where you need to distribute the sterile flies to make that technique as effective as possible. Next slide, please. So as I mentioned, our sterile fly production currently is at the COPEG facility in Panama. And we release those sterile male flies to mate with the female flies. Right now, the facility in Panama can produce about 100 million flies per week. And currently, those flies are all being dispersed in Mexico because that's where the northern edge of our outbreak is. Next slide, please. And so the intention then is to disperse those flies from Mexico, moving southward through Central America to push the fly back down out of Central America. 100 million or 1 million flies a week is not enough for us to be able to handle that in a broad geographic area. So we have started to work with Mexico to renovate a fruit fly facility there to add to our production of screwworm flies that we can sterilize and distribute. And then we are also planning to build a dispersal facility and a production facility along the southern border with Mexico to further supplement. We do expect it to take a number of flies over a number of years to push the screwworm outbreak all the way back down to the Darien Gap, which is our goal. Next slide, please. So on June the 18th, Secretary Rollins announced several different strategies to counter the screwworm outbreak. The first is stopping this pest from spreading in Mexico. So we're working very closely with officials in Mexico to help them bolster all of those eradication techniques that I mentioned, their animal movement controls, their surveillance and public outreach, as well as the use of the sterile insect technique. Protecting the U.S. border at all costs, we've updated our import protocols for animals from Mexico to ensure that we would identify a sterile insect if it were to come. At this, a New World screwworm infestation. At this time, the livestock border ports are closed for animals coming to Mexico while we continue to work with Mexico on their program and making sure that we can reduce the number of animals that might present to our border ports with infestations. With regard to maximizing our readiness and taking the fight to the screwworm, we've really been working closely with our state partners to update response strategies here within the CONUS US in case we do have to respond quickly. We've also started surveillance along the southern border to ensure that we have the best chance possible of identifying any early incursions, and finally working very closely with partners to do outreach and education to travelers and folks who might see wildlife and things of that nature to help us identify and have reported any suspicious cases that folks might come in contact with. And then finally, innovating the path forward. We had several listening sessions to hear about innovative pathways, and we plan to announce or distribute funds through a grand challenge to look for new innovations in the possibility to eradicate or treat New World screwworm over the coming weeks. We expect to have that announcement and that request for proposals out by early October. Next slide, please. So I just mentioned that we were updating a lot of our materials. We updated our Green Book, which is an overarching response strategy, and that's available on the USDA website. That was updated in June of this year. We are currently working with our state partners to update the more specific response guidelines that they might use if they identified a case in an animal in their area, to give them specifics for an operational plan. We just had our last listening session around that playbook last week, and so we expect to have that cleared and ready to post on the website by the end of this month. There are a number of resources that Dr. Barton-Baravesh already mentioned at the beginning available on our website, and so please feel free to review our website for any materials and information that might be valuable to you. Next slide. And so that brings us to, if you have questions or concerns or want to report anything, feel free to use this email address or my personal email address, and look forward to any questions later in the presentation. Thank you.
Thank you. Dr. Straley, you can continue with your presentation.
All right, thanks. And thanks, Dr. Sifford. So, hey, everyone, I'm Ann Straley. I'm a veterinary medical officer with the Parasitic Diseases Branch. I'm here at CDC, and this afternoon, I just want to share a little bit about CDC's preparedness efforts for New World screwworm in the Americas to follow on Dr. Sifford's great presentation. So, next slide, please. So CDC's role in the greater New World screwworm response is to support USDA's preparedness and response efforts by ensuring that human cases can be rapidly identified, diagnosed, and reported, and also working to ensure that USDA has the information that they need in order to be able to implement any necessary control or surveillance measures in response to a human case. So things like the sterile flies that Dr. Sifford just described. We do this by working with public health officials healthcare providers and other partners to provide education, like we're doing right now on this ZOHU call. So we're working to educate partners on clinical manifestations of New World screwworm in humans, how it's diagnosed and managed in people, and also highlighting and reinforcing the importance of appropriate handling and disposal of the larva and the need to activate human and animal public health response if a case is identified. We are also providing laboratory training and technical assistance where needed. CDC has also created a case report form and case investigation guide to gather important epidemiological information on human cases, and we're working to finalize the data management infrastructure to be able to receive and analyze those data. So more to come on that later. Next slide, please. So what do healthcare providers, veterinarians, and health departments need to be aware of right now? So New World screwworm is not currently in the United States, but introductions are possible. We have seen cases of New World screwworm in human travelers returning to the United States after visiting endemic areas or outbreak areas, including the recently identified travel-associated case that you may have heard about. So vigilance is needed to protect both human and animal health. Next slide, please. So when should New World screwworm be suspected? Remember, it is not currently in the United States, so a history of travel to an endemic area or to Mexico or countries in Central America that are currently experiencing a reemergence of New World screwworm is still a key risk factor. So collecting a good travel history is important. The lesions caused by New World screwworm are very painful. People with infestations often report feeling the sensation of movement in the wound, and foul smelling or malodorous bloody discharge is frequently present. The larva may be visible in or around the wound, and there can be extensive tissue invasion and destruction. If the wound becomes secondarily infected, then we could see symptoms like fever or chills. The picture on this slide is of an infested wound in a Canadian traveler who had traveled to Costa Rica and returned with a New World screwworm infestation. Next slide, please. So if New World screwworm infestation is suspected in a human patient, obtaining confirmatory identification of the larva is key. There are other flies that can also cause myiasis or maggot infestations of wounds that are not New World screwworm and that are circulating in the United States. In suspect New World screwworm infestations, it's also crucial to remove and kill all of the larvae. All suspected larvae should be collected and placed into a leak-proof container with 70% ethanol, and the volume of that liquid should be enough to fully submerge all of the larvae. The ethanol will both kill them and preserve them for identification. If you have more than 10 larvae, save at least 10 of them to submit to us for diagnosis. If you don't have 70% ethanol, you can substitute 70% isopropyl alcohol or 5 to 10% formalin. And remember, it is crucial to remove and kill all of the larvae. Don't throw any of the live larvae in the trash or on the ground. This could result in the establishment of a local population of flies. Next slide, please. Suspected cases in humans should be reported to the state or local health department. CDC is available to help healthcare providers and health departments with identification of the larva. So if you suspect a New World screwworm infestation, you can email dpdx@cdc.gov to request diagnostic assistance, or you can contact us in the parasitic diseases branch by emailing parasites@cdc.gov or calling the number there. If it's after hours, over the weekend, or on a holiday, you can always reach us by contacting the CDC Emergency Operations Center. And if you suspect New World screwworm in a human patient, that counts as an emergency. Next slide, please. There are a number of resources that we've developed that are available on CDC's website. They're listed here. So we have a New World screwworm general information page and a clinical overview of New World screwworm geared towards healthcare providers. Both of those pages are also available in Spanish. We've developed a bench aid for identifying the maggots, but if you suspect New World screwworm, please do contact us for confirmation. And additionally, one of my colleagues did a clinician outreach and communications activity, or COCA call, back in October of last year on the resurgence of New World screwworm in the Americas for healthcare providers, and a recording of that presentation is also available online. The first website listed on this slide is the main CDC New World screwworm landing page. So as we work to create some additional resources, including things like fact sheets, additional bench aids, checklists, those will be posted there when they're available. Next slide, please. Okay, so that's all that I have for you today. Thanks for your time and attention.
Thank you, Dr. Straley, and thanks again, Dr. Sifford, and to all of our presenters today. Okay, so we have time for some questions, and we'll move right onto that question and answer session. As a reminder, if you have questions, please use the Q&A feature to send your questions and include the presenter's name or the topic. Okay, let me find, I'm going to start with Campylobacter. So I'll start with the first question. Is it hypothesized that potential biosecurity lapses leading to the recurrence/persistence of this strain in pet store puppies is at the pet store level or more upstream at the breeder level?
Yeah, thank you so much for this question. So I think the crux of my answer here is that it is multifactorial in what is allowing these strains to recur and persist. Particularly in our initial multi-state investigation, we did make recommendations to retailers as well as distributors and such as those using trucks to transport puppies and intermingling different breeds of puppies from different breeders. We did make a number of recommendations to reduce the likelihood that those vehicles to transport puppies or where puppies were housed at retail stores to reduce the chance that there were environmental reservoirs in those instances. But likely there's also environmental reservoirs or other reservoirs that are allowing at the level of the breeder this to persist, while we don't always make it all the way upstream to the breeder. So what I mean there is in all instances in which we confirm a human became sick as a result of contact with a puppy, we don't always identify who the breeder was for a number of different reasons. But what that suggests to me in all likelihood is that there are environmental reservoirs at various breeders that allow persistence. But we did identify in certain circumstances contribution at the retail stores. But in a lot of our recent single state investigations, the outcomes have been that following up at pet stores, there have been generally no concerns about biosecurity that investigators have detected. That's a little anecdotal there, but it's likely also contributing at the breeder level as well. Thank you for the question.
Thank you. I'm going to skip down to New World Screwworm just to make sure that we can get some questions in there. So what for New World Screwworm, what types, and this is in regard to the travel related cases, what types of activities likely resulted in their exposures while they were traveling?
Thanks for that question. I don't know that we have a good sense of exactly what the exposures are that resulted in the travel associated cases that we're aware of. Some of the more historical ones, like the patient may have visited a resort and fell asleep outside, and that was enough to get a New World screwworm infestation. There are some risk factors that can put people at greater risk for New World screwworm infestation. So if any open wound, regardless of where it is on the body, can attract a fly. It can be as small as a tick bite. So important to keep wounds clean and covered. People who may have a compromised immune system or a weakened immune system can also be at risk for more severe outcomes for New World screwworm infestation. There are some medical conditions that may cause, skin ulcers. For example, diabetes, that can be a risk factor for New World screwworm infestations. Things like that.
Great, thank you. And so sticking with New World screwworm, how do you verify if the sterile fly production and dispersal is successful in the areas you release? And I guess another question related, capture screwworm in the same area after 2 to 3 months and check the total population?
Yeah, so when we're releasing sterile insects, we are also doing surveillance in the area, looking for whether there are continuing populations of flies in the area. And once we have come to the point that we expect that there aren't any more flies, we will continue surveillance for at least 2 life cycles to make sure that we still don't see any flies. Some of you may recall that we did have an outbreak of New World screwworm in the Florida Keys just a little less than 10 years ago. And because of the geography of the Florida Keys, it is easier to distribute the flies on those island situations and monitor where they're going and the impact they're having with the wildlife population. But in that case, we did that. We distributed the sterile flies, we monitored the populations, and then once we weren't seeing any additional wild populations, we continued that surveillance for 2 life cycles, which is about 2 months.
Thanks for explaining. Okay, gonna go back to Campylobacter. Appreciate the presentation. Is the lab testing service mentioned in the first presentation more or less limited to canine species, specifically puppies in stores and recently purchased via a commercial sales channel, or can a personally owned pet, puppy, or litter be tested under the program?
Yeah, so what I would recommend there, we've worked with our colleagues with FDA CM on this topic. What I've responded to this question with a comment of their contact information. We also include this contact information on our CDC's website about these persistent strains of Campylobacter. I would suggest reaching out to them in any instance that you're interested in pursuing this testing, and that would allow you to kind of describe the scenario in general. The way we have told the public about this is that any testing for dogs, including household pets or animals residing in a store or shelter that had contact with someone, a person who was infected with Campylobacter, this testing is available. So I would encourage you to reach out to that email address that I provided. It's just vet-lirin@fda.hhs.gov, and they might be able to answer the specifics of whether or not they could perform testing.
Thank you. Okay, and we may have time for 1 or 2 more questions. Any theories for why the New World screwworm broke past the sterile fly barrier despite successfully preventing movement north for so long? Was there reduced release of flies or suspected known movements of infested animals? And then another comment on this same thought process: we can release more flies, but if we don't understand how their range expanded so quickly, how can we prevent this from happening again? And there are other questions on why what might be the reason that the flies broke through the barrier.
Yeah, thank you. That is a great question. And the leading theory revolves around changes in the environment in that area. When the Darien Gap was established as the stop point, it was really a desolate jungle area. And in recent years, it has seen more and more traffic of people and animals moving northward from South America into Central America through that zone. And it's those movements that we expect were the reason that the flies were able to break through that initial gap. And then those movements also appear to be the primary method for the flies to continue their northward spread. We know that there are large numbers of livestock movements, both legal and illegal, and a lot of that movement moves northward through Central America toward Mexico. So that's one of the primary areas that we are working with Mexico on, is to treat animals and inspect them before they move and be certain that we aren't moving any infestations further northward.
Thank you. Thanks for shedding light on these topics. That's all the time we have for questions today, but if you have any other questions, the presenter's emails are on this slide, and a video recording of today's webinar will be posted within 30 days. Next slide, please. So if you can, please join us for the next ZOHU webinar on October 1st. And thanks again for your questions and participation today. This will end today's webinar. Thanks.